Good morning to all. Today's topic of presentation is description of abnormal gaits. And here we're going to deal with the definition of gait, then the normal physiology, that is the gait cycle, then about the description of various abnormal gaits and the condition where the abnormal gaits are seen. It is mainly included in the topic. So first of all, coming to the definition, the primary objective of locomotion can be translated as translation of body from one point to another by means of bipedal gait. Gait by definition is biphasic, bipedal forward propulsion of center of gravity of the body in a straight line with least expenditure of energy. It is rhythmic sequential movement of the lower limbs that moves the body along the required line and maintains stability and conserves energy. So next, coming to a short about the gait cycle, it has got two phases, that is a stance phase and the swing phase. The stance phase is further divided into first the heel is striked on the ground, heel strike, then becomes flat foot, then the mid stance, then taking the heels off and then the toe off, which constitutes the stance phase. Then the swing phase is divided into pre-swing or initial swing, mid-swing, late swing or terminal swing. So these are the classic gait types. So here, as we can see, initially the lower mark things are classic gait types. That is the heel strike, then the flat foot, then the mid stance. We can see at the middle, almost at the middle, the heel off, then the toe off, mid swing and heel strike. Next, coming to another heel strike. But there are new gait types known as, first of all, the initial contact, then the loading response, mid stance, terminal stance, free swing, initial swing, mid swing and terminal swing. So almost 60% of the total gait is constituted by stance phase and the 40 is by swing phase. One gait cycle is measured from heel strike to another heel strike, consists of the stance phase and the swing phase. The stance phase is a period of time that the foot is on the ground. Approximately almost 60% of one gait cycle is spent in stance. During stance, the leg accepts body weight and provides single limb support. And during the swing phase, it's a period of time that the foot is off the ground, moving forward. Approximately almost 40% of one gait cycle is spent in swing, and the limb is limb advancement. Coming to this center of the gravity of the body. The center of the gravity of the body in midline at the position from ground corresponding to 55% of the total stature. With reference to vertebral column, center of gravity occupies a position just anterior to S2 vertebrae. Center of gravity is displaced twice in a vertical direction during the cycle of motion from the position of heel strike of one foot to subsequent heel strike of the same foot. So here in the image, we can see the boy is walking and the curve is the line represents the center of gravity of him. Next, coming to the determinants. The first determinant of the gait is pelvic rotation. Second determinant is pelvic tilt. Third determinant is knee flexion in stance phase. Fourth and fifth are foot and knee mechanics. And the sixth determinant is lateral displacement of pelvis. Factors affecting the gait are either it can be a pathology of muscle function, it can be a pathology of joint function, pathology of sensation and pain. In the pathology of muscle function, there comes central causes which includes ataxia and rigidity. In the peripheral causes, nerve injuries, muscle diseases, diffuse atrophy. Then in pathology of joint function, it's excessive movements as in post-polio residual paralysis, Ehlers-Danlos syndrome, then restricted movements as in contractures and arthritis. And the pathology of sensation, there is loss of proprioception and perceptual defects. Then the pain is other cause for affecting the gait. Coming to the pathological gait. There are various conditions where the pathological gaits are occurring. So first of all, the quadriceps weakness. In quadriceps weakness, forces tend to flex the knee, and the compensatory mechanisms that take place are patient lean forward to bring the body weight anterior to the knee, resulting in a straight knee with excessive plantar flexion, hip flexion, and a forward trunk. If soleus and hip extensors are strong, premature ankle flexion then is the only sign. The knee can be stabilized by using a hand to thigh gait. The patient will support his thigh using the hand. The limb is externally rotated to orient the external force vector medial to the joint axis, reducing the tendency towards knee flexion. The hand-knee gait is when patient physically pushes anterior thigh to prevent the knee from buckling. So here in the image we can see the patient is supporting his knee using his hand, and there will be an anterior trunk bending too. So this is the GIF showing the gait when there is quadriceps weakness. Hope everyone able to see it. Next, coming to pretibial muscle weakness, which mainly includes in tibialis, anterior weakness and all. The weakness of pretibial muscles causes slapping of the foot during the stance phase at the time of the loading response. The compensatory mechanisms that prevent this foot slapping are ipsilateral circumflexion of the limb, and there will be ipsilateral high stepping gait, stepping or equine gait, also known as high stepping gait or equine gait. Then contralateral hip hiking will be there. Instead of normal heel strike, there is slapping of all the foot will be there. So this image we can see she is taking her a high step of the ipsilateral side. Coming to antalgic gait, the patient tries to reduce the weight borne by the painful limb by the following compensatory mechanism. The patient tries to reduce the stance phase of the gait cycle, especially the loading response. The double support phase is increased and there is decreased single support time. There is shortened stride length of the contralateral limb. When the hip joint is painful, there is left of the trunk towards the painful side. Here is the left is towards the painful side. This moves the center of the gravity of the body towards the painful hip, decreasing the moment arm of the body weight to the hip joint. Unlike in central lumbar gait, the left is towards the same side, that is the ipsilateral side where the pain is there. So this is the image showing the antalgic gait, where the left side of the patient is pathological and he is turning towards the ipsilateral side. Next, coming to lateral trunk bending. This term is mainly used in cases of amputated and prosthesis has been used. In the stance phase, it is seen towards involved side in central lumbar. Bilaterally, then it's waddling gait. In the swing phase, it is towards unaffected side. The causes include hip abductor weakness, hip dislocation, coxa vara, hip pain, short limb, fixed flexion deformity, skeletal shortening, discomfort between thigh band and perineum. So this is the image. We can see the left side, his left side is amputated and a prosthesis has been used, and he has to bend towards, laterally bend towards that side due to the shortening of that prosthesis. Coming to hip hiking. In the swing phase, there is elevation of pelvis by quadratus lumborum and abductors to clear the foot. It is seen in cases of ipsilateral lengthening as in the cases of hip flexor weakness, ankylosis in extension, extensor spasticity, equinus or foot drop. The contralateral shortness as in the hip flexor spasticity, hamstring weakness, where the knee fails to flex from ground clearance, for ground clearance. So here we can see the affected side, there is a hip hiking of the left side. Coming to circumduction gait, it is another mechanism to gain ground clearance. It is seen in the case of spasticity, weak hip flexors, weak hamstrings, knee ankylosis, and weak dorsiflexors of foot. So here the patient is circumflexly clearing the ground to clear the ground. We can see his foot prints are there, where the right side is on the straight line, while the left side is circumflexly clearing it off from the ground. Coming to internal hip rotation or into stance, it is seen in hip anteversal, biceps femoris weakness, peroneal weakness, and cerebral palsy. External hip rotation, it is seen in weak quadriceps, weak medial hamstring, pes valgus, weak tibialis anterior or tibialis posterior. Next, wide base gait, it is seen in hip abductor contractures, proprioceptive defects, weak lower limb, genu valgum. Narrow base it is seen in cerebral palsy, which is a scissoring type of gait, and genu varum. These are in the narrow base. Inverted foot stance, it is seen in weak everters, cerebral palsy, tibialis anterior spasticity, spade foot, tibialis posterior spasticity, inverted contractures than the CT area. Everted foot stance, it is seen in weakness of weak inverters, eversion contracture, pes valgus and genu valgus. Anterior trunk bending, it is seen during mid-stance late swing in cases of quadriceps weakness. As we have mentioned earlier, in quadriceps weakness, there will be an anterior trunk bending too, and patient supports his knee with the hand. Posterior trunk bending, it is seen during heel strike mid-stance initial swing in case of weak hip extensors, and it is mainly seen in tuberculosis of spine and name gait is alternate gait. Coming to important one, that is a hemiplegic gait. Here the arm on the affected side is flexed, as we can see in the image, adducted and internally rotated with loss of normal arm swing while walking. Affected leg is in extension with plantar flexion of the foot and toes. The affected leg is dragged in a semicircle, that is circumflexion. We have explained earlier the circumflexion gait. The circumflexion is a part of hemiplegic gait due to weakness of distal muscles and foot drop and the extensor hypertonia in the lower limb. This is most commonly seen in stroke with mild hemiparesis, loss of normal arm swing, and slight circumflexion may be the only abnormalities. So here in the image we can see the patient affected side the arm is flexed and adducted and internally rotated. Also the leg in extension with the plantar flexion of the foot and toes and circumflexion gait. So this is the hemiplegic gait where the patient is walking with a circumflexion gait and he is flexing and internally rotating and adducting his side of his upper limb too. Next, coming to diplegic gait. The patient is normally narrow base dragging both legs. The gait is seen in bilateral periventricular lesions such as those in cerebral palsy. There is tightness of hip adductors which can cause to cross the midline known as the scissoring gait or scissors gait. So here in the image we can see the scissoring, and his lower limb looks like a scissor, and while walking it crisscrosses and forms a scissoring gait. Coming to Parkinsonism gait, the patient has rigidity and bradykinesia in Parkinsonism, and he will stoop forward with flexion at the knees. The patient walks with slow little steps known as a marchi a petit pas, that is back of little steps. He will be taking a small steps, and it is known as shuffling gait. Patient also has difficulty in initiating steps. The patient has an involuntary inclination to take accelerating steps and find it difficult to stop once the gait is initiated, and it is known as festination. So these are this image showing the other signs of Parkinsonism too. From below downwards, he has got tremors and he has got mask-like facies. There will be stooped posture will be there. There will be increased rigidity, hyperkinesia. Then the arms flexed at elbow and wrist. Hips and knees are slightly flexed, and there will be tremors in the lower limb, and the gait, it will be short shuffling steps in Parkinsonism gait. Next, coming to coriform or hyperkinetic gait. This is a gait with irregular, jerky, involuntary movements in all extremities seen with certain basal ganglia disorders including Sydenham's chorea, Huntington's disease, and other forms of chorea, acetosis, or dystonia. Coming to ataxic or cerebellar gait. The ataxic gait is a clumsy, staggering movement with a wide base tilt. Even while standing still, the patient's body may swagger back and forth and form side to side known as situation. Patient is not able to walk from heel to toe or in a straight line, and it is also known as reeling gait. So this is the image showing the ataxic gait where patient couldn't stand well and needed support. cerebellar or ataxic gait is on the GIF. Next, coming to sensory gait. It occurs when there is loss of proprioceptive inputs. The patient will slam the foot hard onto the ground in order to sense it. The gait gets exacerbated when patients cannot see their feet, that is in the dark. This gait is also sometimes referred to as stomping gait, and the common causes are disorders of dorsal column, that will be in vitamin B12 deficiencies or Taylor's dorsal, or in diseases affecting the peripheral nerve, that includes uncontrolled diabetes and all. The loss of proprioception will be there. So here in the image, the child is walking sensory gait. She couldn't feel the sensation or the proprioception of her limbs, and it's known as in the dark. The gait has accepted which patients cannot see their feet, also known as that is in the dark. She couldn't feel the feet. That means it's in the dark. This is the sensory gait. Next, coming to sciatic gait. This is seen when psoas bursa is painful. Hip is adducted and externally rotated and knee is slightly bent. The position releases the tension on the muscles and release the pain. Next, coming to gluteus maximus gait or rocking horse gait. This is seen in gluteus maximus weakness. Here the trunk shifts posteriorly at heel strike to shift the center of gravity posterior to gluteus maximus, thus reducing the effort required by it to keep hip in extension during stance phase. This forward-backward lurching is also known as rocking horse gait. There will be a forward-backward lurching will be there in gluteus maximus gait. So this is the image showing the rock horse gait or gluteus maximus weakness gait, where the patient will be bending forward and backward to compensate it. Next, coming to gluteus medius or trundle gait. In normal gait, during single stance phase, when the weight of the body is on one limb, the swag of the pelvis to the opposite side is prevented by the ipsilateral gluteus medius. When the muscle is weak, the trunk is shifted the same side to reduce the lever arm of the muscle, thus reducing the effort required by it to hold up the pelvis. When this is bilateral, it is known as waddling gait or duck gait. If the gluteus medius weakness is on bilateral side, the patient will be accommodating as a duck gait or waddling gait. Here in the image, we can see the normal side. When the patient is on stance phase on the right side, his gluteus medius on the same side will lift up the pelvis of the opposite side, that is in the swing of the other side. But when there is weakness of gluteus medius, there will be drop of the contralateral side, and to accommodate it, the patient will bend towards the other side. And here in the image we can see the trundle gait. Next, coming to hamstring gait. During stance phase, the knee hyperextends. There will be genuine recurvating gait. During terminal swing, the weak hamstrings cannot slow the leg and it snaps into extension. Next, in unequal leg length gait, in minimal length differences, the difference compensation happens by dropping the pelvis on the affected side, that is lifting pelvis at the lengthier side and leaning over to the affected side. Up to 2-3 inches can be compensated by this. In case of moderate shortening, that is 3 to 5 inches, in addition to pelvic tilt, the affected person walks on the tip of the foot on shorter leg, such as in equinus gait. In severe shortening, greater than 5 inches, the knee on the opposite side may additionally be flexed.
Matthew, I think when you should have elaborated a little more on the gait cycle itself before going into the abnormal gaits. So there are certain prerequisites for a normal gait that you have to mention, as in you need a stable foot, then you need to get an adequate clearance of the foot off the ground, then adequate step length, then proper preposition, which involves the coordinated movement of the ipsilateral hip, knee, and ankle joint, along with the movement of the contralateral hip. Then it should be an energy efficient it should be energy efficient. So these are certain prerequisites needed for a normal gate that you have to mention. And
Okay.
again, you could have elaborated a little more on the gait cycles, the stance phase and the swing phase, the muscles which come into play, which are the muscles which go for eccentric lengthening, then the muscles which go for the concentric lengthening, muscles which are giving isometric stabilization. There are different muscles which play in each stages of the gait that you have to mention. Then secondly, when coming to discussing on the abnormal gaits, you have mentioned the biomechanics of different abnormal gaits. It will be more helpful and useful if you could correlate clinically, like as in if you see how a patient walks with a trundle gait, how his hip and how his pelvis and shoulder will be positioned, or how what is the relation between the shoulder and the pelvis, how does the body sways. Those things could have been elaborated and stressed upon. Can you explain how the clinically the patient would be walking with a trundle gait with respect to shoulder, pelvis, and the swaying of the body?
There will be pelvic tilt in this system. I mean, pelvis will be tilted and the shoulder will be, I mean, the body will be to the opposite side.
Matthew, it is just like Trendelenburg side. When the patient stands on the sound side, what happens? The disease side will not be dipping or tilting. But when the patient stands on the disease side, sound side sags. So to compensate that, the shoulder will be swinging to the disease side. So when the patient walks, when the patient stands on the disease side, sound side will be sagging, and in order to prevent that, the shoulder will be swinging to the same side. So that is a description of Trendelenburg gait.
That in that video, she walks beautifully. But before going to that video, I just want to retain this slide, this particular one which you have shown, Matt. Because first of all, you have to understand what does the gluteus medius do with the normal distance. You are showing it on the left side. When the patient is lifting the other side, the left side figure, when the patient is lifting the one opposite side, the gluteus medius of the opposite side actually prevents the pelvis from sagging and lifting it up, because that's how you can clear the ground. On the other hand, when the patient stands on the diseased side, the gluteus medius or whatever be the mechanism, either a fracture of femur or a disease in the pelvis or a disease in the trochanter or whatever, which includes the fulcrum, lever, muscle power, etc. All those things we are not coming into the picture. When that happens, the pelvis cannot be lifted on the opposite side. Therefore, the sound side sags, which Kishore actually puts it correctly. Yes, sound side sags. That's what is happening on the Trendelenburg test. So the purpose of the gluteus medius normally is to lift the pelvis so as to clear the ground when we are walking. That's exactly what the gluteus medius does normally. But the gluteus medius may be injured or diseased, weak, or the fulcrum, the hip joint is disordered, or there is a injury to the neck of the femur. All these mechanisms can interfere with this normal tilting of the pelvis. That is lost. So normally the pelvis should go up when we are lifting that leg up and then move. But when the disease side is, that is not happening, then the sound side sags. That's what is happening. You should also remember a few things with respect to the clinical examination, because so many people are listening, including the undergraduates. So the other thing which should be mentioned are actually with respect to the hemiplane gait, the circumduction, etc., which you have already dealt, but it should be stressed upon because the patient cannot lift the leg and clear the ground. Therefore, because of the foot drop, that's why he is trying to lift the pelvis bend the knee and try to circumvent, etc. to clear the ground. Otherwise, it will be dragging. The toes will be dragging on the floor, and there will be ulcerations on the toe. You will continue to see such gait. I mean, gait is important in future also. Even though polio has been eradicated to a very large extent in our country, you may not see polio cases as often as we were seeing in the past. But you will continue to see cerebral palsy. You will continue to see neuromuscular disorders. You will continue to see motor neuron diseases and also diseases of the hip. So the gait is there. Assessing the gait, because that will give you the clue what exactly is the diagnosis. Polio is probably one condition where the muscular paralysis remains stationary. That means you will be able to do something on the muscle or tendon. Rest of the conditions, the disease could be progressive and it can cause more weakness. So understanding the gait is very important. Deciding on a treatment protocol. The commonest one, which is normally the student is asked, are the Trendelenburg gait, the high stepping gait in a foot drop, and the sistering gait in an adductor spasm with respect to cerebral palsy. So these are some of the common things. As Dr. Leo rightly put it across in the beginning, we should spend some more time on normal gait, because that is actually one day topic. And these days, every time we are gaining more and more information about the gait mechanisms because of the digital advances. We can introduce transducers to the patient's body and ask them to walk around so that each muscle power can be charted and an appropriate decision can be made. So the importance of the gait is actually, and gait analysis is actually increasing. In larger hospitals and university teaching hospitals, there are gait labs which are actually making the use of the neurologist and the orthopedists and even the orthotists are using the pattern of a study to prescribe an appropriate prosthesis or an orthosis. So it is very important. And some of you may have to take a special courses on gait analysis, etc. in future. This is my feeling, because it's not going to go away. Even though we have eradicated polio, the problem with gait and muscle weakness will continue to be in our society. So you must pay attention to it, not just for the sake of passing the examination, but for continued clinical practice. This is my feeling.
Basically, we should know the definition of gait and should be able to tell when patient is walking few important gaits. You should be able to recognize them. One most important one is antalgic gait. So it is very easy to diagnose antalgic gait. The examiner will ask you, why are you telling that it is an antalgic gait? So the answer should be patient is having pain when the patient is trying to stand on the disease side. So he will try to lift the leg, the diseased leg from the ground as quickly as possible by increasing the swing of the opposite side. Okay, so the disease side is taken off from the ground quickly. How? By increasing the speed of the swing of the opposite side. So you have to look for two things. The patient is quickly taking the foot from the ground on the disease side, and simultaneously the swing on the opposite side is increased when compared to the same side. When you look at the face, patient may be wincing. So this should be properly diagnosed. So antalgic gait may be a common diagnosis in your long case. Second is the Trendelenburg gait. So you should be able to diagnose Trendelenburg gait. You just remember the Trendelenburg test. So when the patient stands on the disease side, sound side sags, and the shoulder swing to the same side. Okay. Third diagnosis is the short limb gait.
Short limb gait is usually demonstrated in our clinical discussions while you take off one shoe and then start walking. So that will be the correct demonstration, easiest demonstration, not the correct, but easiest demonstration how one is likely to walk when one limb is short. by removing one shoe and retaining the other one and try to walk. That's a typical example of a short-limb gait, which anybody can appreciate very easily, demonstrate very easily. Actually, I learned it from Graham Appley himself, and he demonstrated it many years ago in one of our classes. So that is something which is, of course, a painless gait, because if you are normal, the gait will not tilt otherwise.
The gait, normal gait cycle should have been mentioned to be start with. Secondly, the Trendelenburg is made synonymous with gluteus medius gait. It is not correct. Trendelenburg happens due to various factors other than gluteus medius problem, because it can be a fault in the liver, in the fulcrum. Gluteus medius is only the power. It can be due to the liver arm or the fulcrum, that is in the joint itself or in the neck of the feet. It is not synonymous. It is a fact that gluteus medius weakness produces Trendelenburg gait, but Trendelenburg gait is caused by many other factors also. Thirdly, you have not specifically mentioned the high stepping gait, which is very common in orthopedics, where there is a foot drop. You have used it in common with the hemiplegia. High stepping gait is usually seen in lateral oblique palsy, any cause for foot drop. That also must be specifically mentioned. The high stepping gait.
Okay, sir.
In between, I lost the connection. So when the patient is having a short limb gait, the shoulder on the same side will be dipping. So if you look at the shoulders and the pelvis, and most probably, even if you look only at the shoulders, you will be able to pick up a lot of abnormal gaits. The gait can be described by another method also. We describe the gait based on the first rocker, second rocker, and third rocker. So if the first rocker is affected, that is tibialis anterior muscle is not functioning properly, patient's foot will be dragging on the ground when the patient's heel is trying to strike the ground. So in order to prevent that, patient will be flexing the knee more. So they will be having a high stepping gait. And another thing is, a knee problem is a common thing. So in a knee problem, if the pain is there in the knee, or if the knee is stiff, patient will not be able to properly flex the knee. So in order to clear the ground, patient will be doing something called vaulting. Vaulting is just the opposite of shoulder dipping. So the patient will be lifting the shoulder on the same side. So if you look at the shoulder, you can diagnose 3 or 4 abnormal gaits: a swinging, a dipping, a vaulting. Okay, these are the things which are commonly seen in your clinical practice. And a circumluxation gait you will be able to easily pick up. These are the common gaits. And scissoring also you will be able to easily pick up. The point is that you should be able to pick up and you should be able to explain what you are seeing. That is the skill in an examination. The examiner will ask you why you are telling that it is an endologic gait, why you are telling that it is a Trendelenburg gait. For that, you should practice describing the gait. The gait is a difficult topic. The theory part is not much useful in case of a practical examination. You should be able to diagnose it properly, and you should be able to explain it in a proper manner. You should know the definition of the gait also. It is biphasic, bipedal, forward propulsion of center of gravity with minimal expenditure of energy with simultaneous movement of the trunk and the upper limb. So all these points are important. The Kannada അറിയാന്നുണ്ടെങ്കിൽ it will be good. It is biphasic. There are 2 phases. Bipedal means if your child is walking on 4 limbs, it is actually not called a gait. Biphasic, bipedal, forward propulsion of center of gravity with minimal expenditure of energy with simultaneous movement of the trunk and the upper limb. This is the definition of gait. And an abnormal gait is called a limping. A limping child is another question. So you should know limping in a child, how to approach. That is another topic. and you should know how to approach a limbing adult.